asking the questions. So yes, now we're going to be traveling away from the Alps to the Rocky Mountains.
Paul, and regularly the shortcomings of the US healthcare system are pointed out, and I would certainly not dare to try to use it as a benchmark. However, within that system, there are some hidden gems, and as Guy pointed out, Intermountain is probably one of them. So you guys provide about 50% of the care provided in Utah. You achieve an average cost of about half the average cost of care in the US with amazing quality results. You provide care across primary care and hospital care. You have 24 hospitals. So my first question is very simple. How have you organized? How are you managing across primary care and hospitals to achieve those incredible results?
Well, first of all, Thomas, thank you very much for having this sit down with me, and I'd also like to thank the organizers. This is a real honor for Intermountain to be able to come here and be a part of this. The way we've organized our system is really into two broad bands. One is what we call our community-based care, and that is our primary care-based side. That is where we work diligently to stay upstream with care and to try and keep our costs low in the outpatient area. This, again, is mostly primary care. Our other side of our organization, which is where I live, is what we call our specialty-based care. And that's where our hospitals live in our specialty-based care side. And that, as you mentioned, is 23 hospitals, plus a virtual hospital, plus we're trying to build a few more. That being said, we understand the cost of care is mostly in brick and mortar, so we are constantly trying to find ways to keep that specialty side down. It's not as if we live in silos, though. We have constant communication between those two sides, the community and specialty-based side.
And so what are some examples of the things you're trying to put in place to move care out of hospitals and maybe also develop the care you provide in the primary care setting to avoid hospital attendances on both sides of the equation?
Yeah, I think we all recognize the importance of decreasing our costs in our hospitals, and ways we've done that are not unique. Ambulatory surgery centers to get the cost out there, outpatient imaging centers. We use a lot of urgent cares to try and keep people out of the emergency room.
Can you tell a little bit more about that? What is it?
So an urgent care is essentially, instead of somebody coming to a hospital, they come to a freestanding clinic where instead of they having a scheduled appointment, they can just walk in. And this could be anything from someone having minor chest pain to having a cold. And that's the way we try and keep patients out of the emergency room where it's very, very expensive. I'd like to go back to what you mentioned, though, on the other side of us trying to keep costs down is through primary care. We do this through a number of ways. Of course, we have physicians that are fee-for-service, but what we're really working with our primary care is what we call reimagined primary care, where instead of a patient just seeing their doctor and coming in, we have a group of patients, a panel of patients, say it's 1,000 patients, and then we have a team that works around that. So it's a physician, a nurse, a pharmacist, social worker, whatever it is, so that we can stay upstream with that patient and try and keep them as healthy as possible.
And how do these people come together? How do you coordinate them? How do they get coordinated around the patients?
Around the patient. So the team huddles. We use huddles to start each day. So the way a reimagined primary care day will start is that they'll look at their group of patients. They'll have data based on if they've been to the emergency room. If we're worried that someone's getting sick, we may make phone calls to those patients that have just recently been out of a hospital. And then we'll go through the panel and look at what we need to do and then divide labor based on that.
Okay. And you mentioned moving some, when we were preparing this, you also mentioned that out of some of the things you're trying to move out of hospital include even some cardio activities and some things that we wouldn't necessarily think of moving out of hospital. Can you say a bit more about that?
Well, I can, and I will also say that if my hospital administrators were sitting in here, they'd be a little bit nervous when we talk about moving cardiac care outside of the hospital. But when we've looked at our ambulatory surgery centers, and then we've also looked at where we're causing our patients a lot of money. And one thing that we're looking very closely is cardiac care. So that's everything from outpatient imaging all the way to us, and we're not there yet, but we're looking to getting to outpatient catheterization so that it would not even be done in the hospital, it'd be done in an ambulatory site.
Okay, cool. One of the issues we have here in the French system is that, our hospital system and our primary care system very much still function in silos. And we're trying to find ways to, break those silos. I'm curious, how do you get organized and how do you manage those pathways that, cut across the two?
So, yeah, how we keep those two. So another trick that we have is something we call our clinical programs. And if you come from academic medicine, they're very similar to the setup of what you would have for a department. But what we do with these different clinical programs is that we have one focused on heart and vascular, one on oncology. We have one focused on musculoskeletal, behavioral health. Our clinical programs work very hard to say this is what it's going to require for us to keep patients out of the hospital, so let's push them upstream into community, and let's use what we call care process models or standardized care to keep our patients out. And then once they come into the hospital, we use the same care process models to try and get them to be discharged quickly. Maybe I should come in on one of those. So. Let's take, for instance, a child who comes to the emergency room and has banged their head. So what do? It depends where you go, right? If the patient's vomiting, they might get a head CT, they may get blood work, anything can happen. We've developed what we call care process models so that when a patient comes to an Instacare or to an emergency room, there is a process for how that patient will be taken care of. And we measure it. We measure if they had a head CT, we measure if they followed the protocols, and we measure the outcomes of what happened with that patient. And what we found is we're able to decrease our costs and keep our quality just the same. And it doesn't matter if you walk into one of our rural hospitals, which might only have 15 beds in it, in a town that maybe is 1,500 people, or into one of our tertiary quaternary hospitals in our main, in Salt Lake City, which is our hub city.
Yeah. One of the particularities of Utah is that it's not a very densely populated state. So, you probably have to deal with, what we have difficulties dealing with here, which is, access to care in remote areas, which, is a constant debate. How have you managed around that difficulty?
Yeah, so we do a couple of things to try and help, because we have many of our hospitals are what we call rural or critical access hospitals. In fact, 2 of our hospitals have 4 physicians on staff total, so they're a very, very small hospital. What we've utilized to do this is, 1, nurse practitioners. We tried very hard to hire nurse practitioners who will go to those rural areas. Of course, it's a trick because not everybody wants to live in a little tiny town. The other thing that we use is telemedicine, and we rely heavily on telemedicine to get our care there. So if a patient comes in and they have a complicated problem, a stroke, we use telemedicine from a center hub to help that nurse practitioner or physician give the correct care.
Right. I understand 600,000 telehealth encounters over the last 4 or 5 years?
Yeah, that's about right, about 600,000.
Wow. Let's continue with listing some of the issues we're struggling here and see how you guys have handled those. A lot of our emergency departments are on strike right now, right? And so because they have a hard time facing, the influx of patients. Again, how are you managing to keep patients out of the ER?
I'm so glad we do not have that problem, so may that stay French. We do a lot to keep our patients out of the emergency room because we understand how expensive it is and how burdensome it is once you hit that emergency room. So we used the reimagined primary care, which we talked about in the beginning, where we have panels and we're looking at our patients and trying to see who's going to be sick and try and prevent them from getting there. We leave open slots. We use the urgent cares or the instant cares that we mentioned in the beginning. The other things that we do to try and keep patients out, we use telemedicine to do that, and then we also use a phone app where patients can do what we call Connect Care, and they can pop on a phone to use the emergency room or to visit that way.
So how would that work if I'm a patient?
You have an app, which of course is what solves all problems these days, is an app, but this one worked very well. You pick up your app, you click on it, and it puts you in a quick queue. You put in a couple of your symptoms, it gets you to the right provider, and they can go all the way down to prescribing medications or telling you that you need to come into an emergency room. Or if we can, then we'll get you into a primary care visit sooner.
All right. The theme of this conference is around governance, and so I wanted us also to cover a little bit these elements. And if you think about how the system works, Intermountain, what would you say are the few main key success factors in terms of governing that, in terms of managing the performance of your professionals, both in terms of productivity but also quality. What are some of the tricks or recipes?
Yeah. So, well, Thomas, we're not perfect. You kind of mentioned that at the beginning, but we're always striving to improve. We focus around what we call our fundamentals of care. So that's quality, safety, experience, both for the patient, but as well as the caregiver, because we worry a lot about what's happening with burnout. Access, stewardship to keep our costs down, and of course, we're always trying to grow.
And so you measure all of these parameters systematically?
We do.
How do you do that?
Well, we do that from a number of ways. So one, being an integrated health system allows us to look at goals and what we call key performance indicators. So we set our goals from a system, and then we drive those all the way down to the front line. And the way we drive it back up is we use continuous improvement, kind of the Toyota production way, of doing huddles to bring that back from the front line all the way up to our executive level. So we have 2,500 huddles that happen every day in Intermountain. They last anywhere from 4 or 5 minutes to 15 minutes. With those huddles, at our executive level, we'll hear what happens. So if there is a needle stick in one of our little hospitals in a rural community, our CEO will hear about it by 10:15 in the morning, and we can make changes. So that functions well. We also, as you mentioned, we use our fundamentals, and we use that also to help drive performance for our physicians. So particularly around reimagined primary care, those quality metrics are really how they're judged, graded, and paid, more so than on the number of visits that they have.
So they have a system where, beyond the fee-for-service, they're essentially incentivized on those quality metrics.
That's where we're trying to go to, and that's exactly right.
All right. Maybe one last point before we conclude is, I guess when we were discussing, you mentioned that one of the things that is fundamentally different about Intermountain is the role of the patient eventually in all of that. Can you talk a bit more about that? And from kind of a patient's perspective, how is this different?
Yeah. So we live by the mantra that patients come first, and that everything we do has to be patient focused.
We use these words as well here, right?
Okay, so the way...
The only problem is that then it doesn't quite translate into...
Yes, you're absolutely right. So what happens in the old model is the hospitals want patients to come in, the doctors want to see more patients, and in the middle of that is the churn of what happens to the patient. So by looking at quality metrics, by really looking at access, and by actually realizing the fact that we have lots of people who are trying to disrupt our area, and who are trying to take the patients away, right? So everything we do has to be focused on the way we look at patients. But it's really about using these metrics. It's about using reimagined primary care. And it's understanding patients don't want to be in a hospital, so what can we do to keep them out?
Right. And so transparency, collecting the data, measuring things is kind of a central brick, I guess, right, of the governance of your system.
Measure what matters.
All right. Well, thanks
Thomas,
for sharing all that. Thank you.
Appreciate it.